welcome to the Northeast South Dakota AHEC and South Dakota District 4, EMS District 4 monthly webinar. If you guys have your cameras on, by all means, you can go ahead and turn them off. You don't have to have them on for me. So I actually appreciate it if you do turn them off. I was trying to be nice there. It does sometimes distract me when I'm instructing, so sorry about that. All right, so you guys are stuck with me tonight. I must have done such a good job on this last year that Michaela asked me back to do it again. So let's just make sure everybody's got their microphones muted, please. And I'm getting a call. I wonder if it's related to this. Hold on one second. Nope, not related to this. All right, so a couple quick things before we get started tonight is this will be our last one of 2022. We will not see you again until January. Am I correct on that, Michaela?
Yes. Yep.
Okay, good. I thought so, but so we'll be coming back to you again at the end of January. So watch for the emails, watch the website, and all that good stuff. A couple things coming up in the EMS world. We just finished up conference end of October, beginning of November. It was a great conference as always. We've got refresher season coming up. Ours is going to be February. Help me out here, Michaela. I don't have my 2023 calendar up.
17th, 18th, and 19th.
17th, 18th, and 19th. Presentation College, Aberdeen, South Dakota. We are going to partner with District 1 from down Watertown South area. So it's going to be bigger and better than it's ever been, probably. So be ready. We will have a full slate of speakers for that. I missed the meeting yesterday, but the meetings have kicked off already, and it sounds like got a great start on it. So if you're interested in getting more information on that, you can go to the District 4 Facebook page. You can contact Jackie Rao, who is our treasurer, for more information on that. I think the flyer's out, maybe not on the Facebook page yet, but it's going to be very shortly. So be watching for that. Also February, our friends at the South Dakota Ambulance Association, they'll be having their conference in February as well. So if you're interested in that, go ahead out to their webpage and check on that. Also just set it up on Monday night is March 25th in Aberdeen, South Dakota. We are going to be holding the Northeast District Fire School, and we will also have EMS hours available for that. So if you're marking calendars and trying to get hours, go ahead and mark that one. More information to follow on that. We just set our date. We don't have our location nailed down yet. We're pretty positive where we're going to be, but we just don't have a absolute yes on it. So that'll be in Aberdeen, March 25th. And we'll have EMS hours available for that whole 6-hour day. Multiple instructors, fire, EMS, all sorts of good stuff happening that day. All right, without further ado, if anybody's got any questions, please put them in the chat box. Michaela will be taking a look at the chat box as we go through tonight's presentation. As I say always, when I am doing the OB section of this, I am in no way, shape, or form I'm in no way, shape, or form an expert in this side of things. I have just kind of latched onto a presentation that seems to work really well, and I have been asked to do this again. So I'm happy to be here. I do enjoy doing this one. It's a fun chapter to talk about. And if you guys have any questions, comments, or concerns as we go, please put them in the chat box or just kind of chime in as well. All right, so I'm going to go ahead and stop my video. And I think we can still see the screen if I'm correct. Yep. So that's good. All right. So what we're going to talk about tonight is we're going to go ahead and discuss triage of the laboring patient. We're going to outline the resuscitation side of things. We're going to try to describe the steps for performing a vaginal delivery out in the field. We're also going to describe the steps in resuscitation of a newly born infant out in the field if they do, if they aren't quite as active as we want them to be. So here's our presentation. And those of you guys might remember this from last year. I haven't changed a lot on it. It's a pretty good presentation. So we're just going to roll with it and use it as a review. So our case presentation, we're called to the scene of a 20-year-old woman who's in labor. Our ETA to the scene was, we're going to back this up a little bit because we're in rural South Dakota. Our ETA to the scene was 15 minutes. Our ETA from the scene to the nearest hospital with delivery services is going to be 42 minutes. So we're taking it up to 15 minutes, and our ETA to the nearest hospital with delivery service is between 32 and 42. I have an area in mind where we could go one way and we could get to a hospital. It doesn't necessarily have delivery services, but would be more than capable of delivering. The other way would be coming into Aberdeen to deliver. So 15 and 30 to 40 is what we're going to use there. All right. So what are we going to do when we're en route? We're going to be thinking about what we're going to be needing. We're going to be triage the laboring patient. We're going to be thinking about what we're going to be doing there. We're going to be reviewing our steps for vaginal delivery. We're also going to be reviewing our steps in the resuscitation of the mother and the newly born in case we do have some issues. So in emergency delivery and care of the infant in that first 24 hours, that's where we're termed newly born. That's a very vulnerable period and can also be challenging to the pre-hospital professionals because we're not used to doing things like this. When we talk about these calls potentially coming in, and I say we're going to be reviewing en route, you guys are probably with me on this one. We are really going to be reviewing en route because these are very low frequency, high intensity, high blood pressure type events. So we don't usually get these when the weather's very beautiful outside. I mean, here and there you will. These are usually going to be ones that happen because of some weather issues, whether it is snowstorms, ice storms, things like that. I always think about that when we have these snowstorms and ice storms that come through is, are we going to be delivering out in the field potentially with someone because of this storm? So, and right here it is. So you arrive on the scene, you find this presentation. It's too late to retire. It's too late to resign. You're there, you're in it. It's time to go. So what's our next step in our care for this patient? It's going to be get ready for imminent delivery, right? We're going to put our catcher's gear on and we're going to go to town because it's time to work. So our two simple questions that we want to know: is this your first delivery? If not, how long was the labor of your first delivery? If mom says, oh, it was really fast, like 30 to 40 minutes, well, we're probably going to be delivering. One thing I'm going to throw out there, since we are really rural in our areas, a lot of our areas are very rural, is think about this. You don't necessarily have to do it. I'm not telling you have to do this, but why don't we think about dispatching the next nearest ambulance to our scene? Maybe we've got 2 in our area. Maybe we've got 3, maybe we got 4, whatever. Take 2 rigs because we essentially have 2 patients. And if we are going to be caring for or having to do resuscitation on either one of these patients, it's going to help us to have a whole second crew with us. And I know some of you are thinking, well, we only have like 5 people on our entire ambulance service. Well, yeah, but then call the next town over and have them bring a rig, because if things go south, it's a lot easier to have 2 ambulances or even 3 ambulances sitting in that yard, maybe one for dad too. Maybe have 3 ambulances sitting in that yard instead of being in the midst of it, now we have a resuscitation going on with either mom or infant or newly born infant. And we're sitting there thinking, man, we should have called for some help. So think about it. If you think it's a good idea, maybe put it in your protocols. Maybe have this as something that is something that you do when you get called for a patient who's in labor. Go ahead and make that pre-arrival call on scene. It does not hurt anything to be ready instead of be standing there thinking, man, we should have called 15 minutes ago. And I know some people are going to argue with me every single day on that, but I will tell you that the way we're training our new EMTs out there in the field is to call early and to call before you arrive on scene, because it's always a lot easier to turn those other rigs around than it is to get them on scene 15 minutes after they should have been there. So another thing to think about when we talk about, is this your first delivery, is we're going to talk about gravida and para. So for those of you that maybe don't know what that means, is gravida is the total number of times that our patient has been pregnant. So if this is this lady's first pregnancy, she's going to be gravida 1 and para 0. So para is going to be when there's a delivery. Doesn't necessarily always have to be it has to be a live birth. That child may have had something going on and they died after the fact. It's still, if it's a live birth, it's considered para. So if this is her first child, gravida 1, para 0. Once she delivers, if it's a live delivery, gravida 1, para 1. So it's important to understand why that comes into play. Is if we have a patient who has had a history of miscarriages or pregnancies that resulted in maybe a stillborn infant or whatever the case is, we kind of need to know that, because that also is going to help us prepare in how we go about who we're going to call, and potentially having more backup there, because we could have something that is some sort of a congenital issue where our infant might need some resuscitation. So anybody have any questions on that? The other thing, I guess, before we open up for questions, is going to be the multiple pregnancies. We still count those as one. Even though we have multiple births, they're still counted as one. It's one event. Pregnancy is one event, delivery is one event. So, and I did reach out to an OB professional today and get that so I'm sure on that one. So anybody have any questions, comments, concerns on that portion? Hearing none, we will keep going. Also going to ask mom, do you feel the urge to push? If that's the case, our delivery is going to be within 30 to 60 minutes and possibly even sooner. So if mom's feeling urge to push, and we just said we have a 30 to 40 minute transport time, is it okay to put her in the ambulance and try to deliver on the road? Or should we just stay in that nice warm house where we know we're going to not be bouncing down the road and have to deliver in the back of the ambulance? Going to be a decision you have to make. And I would not take that decision lightly. I would get on the phone with the emergency room, get on the phone with medical control and medical direction, and ask them and get their input as well. Essentially, it's going to be your choice, but get their input. If you guys didn't hear, I'm battling what everybody else has. Ear infection, RSV, cold, you name it, I probably got it. So, except COVID, I'm negative on COVID. So if my voice tends to go tonight, just bear with me. My voice is about the best it's been the last 3 days. So, all right, moving on. So we are triaging our laboring patient. We go ahead. And we're going to conduct that brief physical assessment. Is that child's head crowning? Is the head or scalp visible at the perineum during contractions? If that's a yes, that means delivery is imminent. Are we having contraction and we can see that head starting to progress through the birth canal? and then it ends up, after the contraction is over, it's not as visible, it means we're going to be having a second patient here shortly. But kind of base our transport on that, if we have crowning or if mom feels the urge to push. Now, talking about breech deliveries, 4% of term deliveries are breech deliveries. Inspection of the perineum will show a head crowning, but another anatomic part such as feet or buttocks might be visible as well. Breech deliveries do carry a lot higher risk to both the infant and the mother than the normal deliveries do. So given the risk and the potential that we need an emergency C-section in this, we're going to go ahead and we're going to initiate transport to the hospital as soon as we can, as soon as we've identified that we may have a breech delivery, even if delivery does appear imminent, because we're not going to be able to do a whole lot. And chances are, if we do deliver that way, we're going to have some issues in the in both of our patients. So back to our case progression here. We have our mom. This is her second baby, so we're going to call her Gravita 2, Para 1. So she's had 2 pregnancies, 1 live birth. She states that the labor with her first baby was short, 2 hours, which is kind of uncommon, but not totally crazy. Usually that first baby takes a little bit longer, but not always. She does feel the urge to push. So if we go back to what we were talking about, is we're going to have an infant within 30 to 60 minutes and maybe even a little bit sooner. So we have to make that decision depending on what the weather is, how far our transport time is. We said 30 to 40 minutes, and make that decision if we are going to be staying and welcoming a second patient, or if we are going to give it a try and try to get to the hospital. The comment that I always get from folks is, well, we're going to drive really fast. Is that really the best thing to do for a mom who's in the very near stages of labor, is to drive really fast? Probably not. It's unsafe, and we are not going to supersede that speed limit by more than 10 miles an hour, because the last thing that we want to do is have an accident and cause a lot more problems. So we are fully capable of doing this in the field. As long as everything's working right, we are fully capable of delivering. And baby and mom hopefully will be okay if everything goes right. So some things to also think about when we're talking about resuscitation oriented history is, are you having twins? Is it a multiple birth situation? When are you due to deliver? When is that due date? Are we really close to it, or are we farther away? That's also going to play into account on what we're going to need for extra help as well. Because if we're talking premature infant, that infant's probably going to maybe need some help breathing and some oxygen. If we can get to the hospital, we're going to give it a try. Or if we can even intercept with an ALS agency as well, that might also play into how we're gonna roll with this one. What color was the amniotic fluid when the water broke? Was it a clear, or could it have been meconium stained? Those are all questions that we're going to ask. All right, multiple deliveries, going into that. If twins or multiples are expected, prepare for more than one delivery. How many OB kits do we carry in our ambulance? Probably one, and it's covered in dust, and we don't know where it is because we don't ever want to use it. If you do have an OB kit that's kind of outdated or whatever, take it out, mess around with it, show everybody what's in it, understand what's in it, and train with it. So we're going to need to prepare extra equipment. That's where our second ambulance comes into play. If we show up at this house and she's like, yep, I'm having twins, and we got a raging blizzard outside, it would have been probably a good idea to grab either our second rig or start calling for another one to make it through the snow to get to us, because we're not going to have the equipment for it. All right, so now emergency deliveries, they're pretty common for preterm babies less than 36 weeks. And I think they're even going as far out as last time I heard is there's been some recently born at 25, 26 and have been fine. And even prior to that, a lot of those numbers are just kind of based on the advancements in OB and delivery sides of things. I know some infants have been born very early and have survived and just fine. But there is kind of a cutoff for providing life-saving treatment on them, as if that patient's viable even at all. And without saying exactly what that is, because I haven't looked it up for a couple of years, I do remember a number of years ago it was like 23 weeks, 24 weeks, somewhere in there. So that'd be something to look up after this class to see where that kind of cutoff is, to where that patient is even technically viable to live outside the womb. Knowing the due date, that's going to be very important in preparing our right resuscitation equipment for our airway management and breathing support. So make sure that we have the masks that are sized for preterm infants. One thing that when I get around to different ambulance station is we just have the pediatric mask. We're not thinking about an infant mask. I can guarantee you that all of you have probably infants in your jurisdictions. And if one of those infants has a medical emergency, our pediatric mask is not going to work for them. So go ahead and purchase that premature mask so we can deliver oxygen to these premature infants and at least give them a chance. If you're on the ALS side of things, make sure that you have the right endotracheal intubation equipment ready for a premature infant as well. Our meconium stained, that's going to be that greenish color. That's where the fetus has passed the fetal stool right during that time frame of where labor comes into play. It also does indicates the intrauterine stress, and also will indicate hypoxia as well in our infant. So we may have to use our suction, and may cause vagal stimulation with our patient, and could also lead to bradycardia with our patient. So now we're bringing them out. We are aggressively suctioning, and now we're lowering their heart rate because we have to aggressively suction out that fetal stool that is in their nose, their mouth, so that they're able to breathe. So now we're progressing with our case, and the patient states only one baby. She is near term. She's within a week, and the color of her amniotic fluid is clear. Those are all three really good things. We should be jumping up and down and saying, oh yeah, we got this. This is all good stuff. So what equipment are we going to need for delivery? We are going to need that OB kit that is covered in dust, that is hidden in the ambulance in places that if it's out of sight, it's out of mind, right? That's really not the case though. We still need to get it. We still need to use it. So we're going to need that OB kit. We're also going to need blankets. We're going to need probably sheets off of our cot. We are going to need some stuff for us. We are going to need safety glasses. We are going to need face shields. We are maybe even going to need gowns, because it's when stuff gets rip roaring, we're going to get blood and body fluids flying all over the place. So we want to be ready to go. So how are we going to position mom? If you guys remember last year or 2 years ago, whenever that was, I did this one last, is I had probably one of the smartest OB nurses I've ever had the ability to chat with on the call with me. I tried to get her today, but she's actually working. She went back to the OB ward and she's working tonight. So she told me that I had it. So I guess you guys are just stuck with me. But when she talked about, I gave her the opportunity to talk about these different positions for mom. And it's not always just that supine position that's going to work the best, especially when we're at home. So the supine on her back, that is you want to kind of on the side of a bed, so we can get in there and kind of let gravity also help us as we're delivering the infant. Suction the baby's mouth and knows before delivery, that's going to be difficult if the mom is in that position in kind of the middle of the bed like she is. So we want to let gravity help us. So we kind of want her more towards the end of the bed, so gravity can help us with everything that's happening. And then we get into the Sims position. This is where the mom's going to lie down on her side with her back towards the attendant and her knees drawn towards her chest. In this position, the infant's head is easy to reach for suctioning before delivery. So I would say if we're talking meconium stained and we are able to do this Sims position, this is probably one that we might want to look at doing, because we want to get suctioned as quick as we can with that infant. If mom says, when my waters broke, they were that greenish color, that's going to give us an idea that that infant has had a fetal stool, and we're going to be dealing with that now. So some other ways that we can do this on the edge of the bed, and we can set chairs up so mom can put her legs out there. The advantage for this is it's going to be the best position for the baby at the perineum. It's also going to be, we could possibly have less tearing this way potentially with our mom, but not necessarily the other way. We can still have some tearing here as well. Disadvantage of this is we've got to be catchers, and these little guys are slippery, right? So we've got to be ready. We've got to be ready to go when we're in this situation. But gravity is going to help us with a lot of things in this position. Most babies really deliver themselves without assistance. When they're ready to come out, they're coming out. Although us as EMS professionals, we might attempt to control the delivery, we really don't want to interfere much. We want to let that natural process happen. Allow the mother to push the head out, reduce that nuchal cord. 50% to 60% of all deliveries, we could end up with some pressure on that area. If that's the case, we're going to go ahead and feel for the infant's neck, feel for that umbilical cord with one finger. And if it is wrapped, we're going to go ahead and gently lift it over the patient's head or over the baby's head. We're not going to pull hard on the cord, as it could cause an avulsion to the cord, and we could end up having a severe hemorrhage that way as well. So allow the mother to push the head out, push the head of the baby out, and then that baby is going to end up turning, and we're going to go ahead and deliver that way, just as you're going to see right here. So we're going to just support. We are going to just be ready to kind of catch. There might be some occasions where that infant's anterior shoulder might need to be pulled posteriorly to clear the mother's pubic bone, and it can be accomplished by placing a hand on either side of the infant's head and then gently pulling downwards. It's all we got to do is we're pulling downwards for that shoulder to clear, and then they're going to be coming on out. Not pulling out, just pulling downwards. Deliver the baby, keep the baby at the level of the vaginal opening as well. If we're on the edge of that bed, we're going to kind of hold that baby up there a little bit. Or we could slide mom back. We could slide our chair, kind of slide a second chair in there or a third chair in there. We can do a lot of good stuff with things that are in the house. We're going to go ahead and tie the cord in 2 places and then cut it. This is probably another opportunity for us to have medical control on the phone and let them kind of help us walk through this, because again, not something we do every day, not something that, I've known EMTs who have been in the service for 30, 40 years. They've never delivered an infant, and good job to them for missing that one, because I've been involved in one. And I know there's been a lot of people that have been involved in a lot more of them. So, get medical control on phone. All they can do is help us. So it's not a bad thing to have them on the phone. They will help us and guide us through some of these next steps. If we hold that baby with an unclapped cord below the level of the uterus, it can lead to a transfusion of blood from the placenta of the baby, leading to a dangerously high hematocrit. So we don't want to have that transfusion happening. So we get the infant out, we get that cord clamped and we get it cut. Again, like I said, probably on the phone with medical control, letting them kind of help us. So the baby will be born face down. We're going to suction the baby's mouth first, then the nose using the rubber bulb syringe that's in our trusty dusty OB kit. Suctioning is going to help and clear the airway out from the mucus, amniotic fluid. It's also going to make that transition from being in the womb to breathing a lot easier for our patient. Once we get going, the last step of delivery is going to be the placenta, which could take anywhere from 10 to 15, maybe even sometimes 20 minutes. Once we get past 30, that's kind of a little bit longer wait. Delivery of that placenta is not going to be an emergency procedure and must not delay transport of mom and infant. So as soon as we get infant out, we get infant stimulated. Infant is crying. Infant is active. We're going to go ahead and put infant on mom's chest, and we're going to transport. I know you're going to hear the EMS for children people yell at me for saying put infant on mom's chest, but in our part of the world, especially in the temperatures that we have, that's going to be our best way to keep that infant warm and not have them start to exhibit the signs of hypothermia. So we're going to wrap them up tight, put them on mom's chest. We're going to go ahead and strap mom in as best as we can. And we're going to tell our driver that we do not need to drive fast. We are going to drive normal speeds. As long as everything is going good, we can go normal speeds. We can even go non-emergent back to the hospital. Essentially, we do not have an emergency anymore if everything's working right. So we're not going to pull on that umbilical cord to hurry that process, because we could rupture that and we could cause a hemorrhage to mom. And we don't want to do that. We've just done such a great job with this. We don't want to cause any issues. But now our case progression says we did a great job, but we've got some issues going on. So our baby's born limp and lifeless, no respiratory effort, and the baby's blue. What do we do now? Again, too late to retire, too late to resign. We're in it. We got to go to work. So now we got to go to the resuscitation side of things. So dry, warm them up, position them, suction them, stimulate the infant the best that we can. If we have ALS folks, the ALS interventions aren't really going to be any different than what we're going to be doing. So we're going to go ahead and assess our breathing. We're going to go ahead and assess the heart rate and assess the color. Now, when we get into neonatal resuscitation, there are some ALS interventions that can happen. But in field deliveries, the ALS folks are going to do a lot of the same things that we did. So we're going to go ahead and get the wet towels, wet blankets from around the baby out of there. Dry the baby, stimulate the baby. Should take no more than about 5 to 10 seconds. We're going to clear that airway with the normal nasopharyngeal suctioning, that bulb syringe. If our baby is breathing, but the heart rate is less than 100, we're going to go ahead and start our big mass ventilations. We want to get that heart rate up to 100. In this case, it's going to be important to emphasize the need to quickly dry, stimulate, and clear that nose. If our baby remains apneic, airway management must proceed without any further delay. So some evidence suggests that hyperoxia can be harmful in our new infants. Do not give supplemental oxygen to the rigorous newborn. If we have a baby that's born just fine, we don't need to give them oxygen. We don't want to over-oxygenate them. So although there are negative effects of hyperoxia, high oxygen saturation in the newly born, if the baby is just distressed, the goal in the field is should be to ensure that adequate oxygenation through administration of the supplemental oxygen and assist ventilations when needed. So don't hesitate to use oxygen if we have an infant who's not rigorous. So we've worked, the infant remains apneic after the initial steps. What do we do now? So most babies will be crying, indicating adequate respiratory effort. A crying baby in this position, in this instance, is the best crying you're ever going to hear. Breathing effort could be slightly irregular. We're going to just keep an eye on that. Gasping or the grunting are signs of increased work of breathing and respiratory distress. We're going to want to have our bag valve mask ready to go in case we have to help breathe. If we have that apneic baby, no visible respiratory effort, we're going to require that immediate treatment. So we're going to go ahead and extend the head slightly to the neck. We're only going to go into what's called the sniffing position, which is where that baby's nose is pointed straight up at the ceiling. We're not going to overextend it because we could cut off the airway from the backside because they really don't have any necks and there's no muscle tone there. So if we overextend that neck, we potentially could shut the airway off from the backside. We're going to go ahead and perform the EC clamp method with a C around the pediatric mask or the infant mask, and then using our other 2 fingers or 3 fingers to kind of keep that airway in that sniffing position. We're going to ventilate at a high rate. We're going to ventilate at that 40 to 60 breaths per minute. We want to get that heart rate up and we want to get that infant going. So we want to also avoid pressing too hard on the baby's face while we're holding that mask on there. Should be relatively easy to get that mask seal with these guys. They're going to be a round mask. It's not going to have the nose outlines or anything like that. So going to be a round mask. Should be able to get that seal relatively well. If we do press down, we could end up triggering a reflex that actually causes bradycardia. So lift that baby's jaw into the mask with the EC clamp technique and breathe at a rate of 40 to 60 breaths per minute. Now, we don't need to give them the entire bag. We're looking for chest rise. These little guys have everything kind of crammed into their little abdomens and chest areas. So as soon as we see that chest rise, that's where we're going to stop. We do not want to overinflate those lungs. So in our newly born, a low heart rate is usually due to hypoxia. We need to get oxygen going, not usually anything cardiac. The crying active baby usually has that adequate heart rate. Assess the heart rate carefully for our baby who is not active and who might require some assisted ventilation. The most easily accomplished by palpating a pulse at the base of the umbilical cord. Count the number of beats over 6 seconds and multiply it by 10. Sometimes those vessels are constricted so that pulse is not palpable. So we may have to use a stethoscope over the left side of the chest to get our beats. Now, if we have our heart rate and it remains at under 60 breaths per minute or 60 beats per minute after 30 seconds of our bag mask ventilation, we're going to go ahead and begin chest compressions. A little bit different than our normal chest compressions. Now we're going into neonatal type CPR. 3 compressions to 1 breath. Pause to deliver that breath. Then we're going to be given 90 compressions and 30 breaths, about 120 events or so per minute. So we're cooking along. We got to be rolling, and we're going to go ahead and use our encircling thumbs technique here. Compress at a rate of 120 compressions per minute. Again, 90 compressions, 30 breaths is what we want to see here. For ALS side of things, you can start looking at epinephrine. You can start looking at the route. The IV route is going to be usually potentially through that umbilical cord, if that's our way to go. Otherwise, we can consider an IO in these patients. If our newly born is experiencing shock, that poor perfusion, weak pulses, the poor response, we're going to go ahead and treat that infant for shock, and then we're gonna rapid transport to the hospital, probably calling ALS as well. Also could think about on the ALS side is our IV access, IOs, intravenous if we can. Umbilical venous is going to be if trained. Now, if you have neonatal resuscitation or critical care neonatal resuscitation, you're going to be trained in how to do that on the ALS side of things. Fluid resuscitation should be limited to 10 mils per kill. This is where we're still going to get out our Braslo tape on these little guys, and it's going to help us. So now our inverted pyramid here, we are going to be using this to look at things. The temperature, assess and support our temperature, warm and dry that patient. Our airway, position and suction, breathing, stimulate them, circulation, heart rate, and color. Always needed. We're going to always need dry, warm, position, suction, stimulate, oxygen, possibly. Establish our effective ventilation, whether it's bag mask device or if you are ALS and do the endotracheal stuff, chest compressions if we're below that 60, and then on the ALS side, medications if needed. So here we go. We're progressing. After vague mask ventilation for 30 seconds, the heart rate increases to 140 per minute. Yes. The baby becomes pink centrally with cyanosis only to the hands and feet. Yes, we're getting somewhere. Baby begins to cry. You discontinue the vague mask ventilations. You wrap the baby a dry blanket and hand him to the mom. And now we focus on our second patient. Depending on your local protocols, you may want to use the infant restraint seat. Again, our friends at EMS for Children have gotten those out to a lot of your agencies. Again, that's going to be up to your local protocols. I'm not going to tell you how to do things. So make sure that you know how to use those restraint seats and how to put those in the ambulance. Baby's going to be secured in a rear facing position. Secure the seat to the ambulance and keep that newly born infant warm. Also going to be, you can't forget about mom. So we're going to make sure that she is not bleeding, making sure that she's not having any problems as well. When I talk to her, make sure we aren't forgetting about her. A lot of times when we have an infant that is in distress, we kind of tend to forget about mom. So we want to make sure that we have one of our EMTs designated to mom, no matter what's going on in the back of that ambulance. So some of the other transport considerations with our newly born, potentially secure them to the backboard if needed. Probably not one of the first things you want to do there. Make sure we can provide our airway management if needed. Make sure we're keeping that baby warm. We're going to be keeping that baby warm to the point where we are sweating in the back of an ambulance. And I'll sweat in the back of a 50-degree ambulance. So we crank it up to 80, 90. It's going to be warm. So crank that heat up as best as we can. In that kit that you have, it's going to have a small knit cap that's going to cover the baby's head so we don't lose heat at the head. And then again, like I said, crank that heat up in the ambulance, skin to skin contact with the mom, cover both of them, maintain that infant's temperature. The depressed newly born or premature, we're going to go ahead and possibly check those folks for hypoglycemia. And that is going to it's unlikely to develop in the first 30 minutes of life. So if our transport time is longer, we're going to go ahead and get a sugar on those folks, on those infants that are newly born, that are kind of depressed or definitely premature. So after delivery of the baby, there's no maternal hemorrhage. Outstanding, right? You prepare to transport the baby in the mother's arms, restrain the mom on the gurney. Again, if that's your local protocol, that's how you're going to do it. If your protocol is to set up the infant restraint device, go ahead and do that. We get to the hospital. We're high on life, right? We're happy. This all worked out. You deliver the infant and mom to a postpartum unit. Baby and mom are admitted. They get a night stay and they're discharged the next day, and you get your stork pin. So although we have that most field deliveries are normal, the rate of complications is higher for those out of hospital births. And I'm not sure where we have everybody on from tonight, but some of you folks who are in certain areas, in some of the reservation areas, some of the more impoverished areas in the state, the prenatal care may be at a very minimum. So there may be stuff going on with that infant that we don't know about, or that mom doesn't know about. So do the best that you can with what you have at that point in time. Positioning, suction, and drying are the only interventions really that are usually needed. In that depressed newly born, use that graded approach for management. And that graded approach is going to be the APGAR scale. So when we talk about the APGAR scale, and we talk about our infant who was lifeless pretty much right away when we got him out, their APGAR scale is essentially 0, maybe 1 because of the color that we had. So our heart rate's going to be 0, 1, 2. 0 is going to be no heart rate. 1 is going to be fewer than 100 beats per minute. And number 2 is more than 100 beats per minute. Our normal APGAR scale is going to be that 7 to 10. So as I read through these, you guys can kind of think about that. So Our respiration, again, 0 to 2. 0 is going to be not breathing. 1 is going to be that weak cry, might sound like that whimpering or grunting where they're really working hard to breathe. Number 2, good strong cry. Muscle tone, if they're limp, lifeless, 0. Number 1 is going to be some flexing or bending of the arms and legs. Number 2 is going to be that active, aggressive motion. Reflex response, 0. Again, no response to airways being stimulated. Number 1 is going to be a grimace during stimulation, and 2, a grimace and cough or sneeze during stimulation. So color, 0. The baby's entire color is blue or pale. That's 0. Number 1 would be good color in body, but the blue hands or feet. And 2, completely pink or good color. So once we got our infant going, we had a good heart rate. So we had a 2. We had a good respiration rate. That's a 2. So 2, 4. We had active motion, a 2. So we're at 6. We had a 2 with our sneezing, crying, grimacing. So we're at 8. And then our color, we still had some blue hands or feet. So we're at a 1 there. So we have a 2, 4, 6, 8, 9 on our APGAR scale on our infant. And once we got them going, prior to them getting going, we had them at about a 1. So, or even maybe even a 0. So that APGAR scale, that should happen at 5 minutes. And then also, I'd say probably every 5 minutes for up to 20 minutes. Retested every 5 minutes for up to 20 minutes. So you guys have your next meetings, review those steps of how you're going to handle a delivery at a scene. Proper triage decisions. Again, always remember childbirth is a natural act, and usually we only have to have minimal intervention from us. And in that newly born, if they're depressed, oxygen and ventilation are going to be the keys to getting that infant going. Some of the things to talk about a little bit is, let me stop our share, get my camera on. All right, so when we're talking about this time of year, and I know a lot of you just looking at the list, you guys have critical care access hospitals in your area. It's probably a really good idea to go have a conversation with those folks and say, okay, we get in the middle of a blizzard or we get in the middle of an ice storm and we have a mom that's in labor. Can we bring that patient here? Their first words are going to be, hell no. But then you're going to have that conversation with them and they're going to be, absolutely. We can do it if we have to. I know a couple of years ago, I don't know if we have anybody on from Britain tonight. A couple of years ago, there was an infant that was born in Britain for the first time in a number of years. And they're set up, not necessarily set up to do it, but it is a controlled environment where you have more highly trained medical professionals with you. So if that's your choice, that's your choice. Don't hesitate to do it, but make sure you're having that conversation. So you don't just show up with a mom who's crowning and say, hey, we need your help. Here you go. Have that conversation. Make sure you're communicating with your hospital, whether it's a critical care access hospital or a larger hospital who is set up and does do deliveries. Make sure you're communicating that you're going out on this, and so they can be ready and they can call in extra help if they need it as well. All right. So with that, anybody have any questions, comments, concerns? Again, I'm not an expert. I have just learned from some of the very best in this and have grabbed onto a couple of things and enjoy talking about this, believe it or not. I never used to, but it is kind of a fun topic to talk about. So anybody, any comments, any concerns, any questions? Oh, let's see here. Looks like we just had some audio trouble. Have I delivered any in the field? One. Yes. Happened in, I forget the year, 2007, I think. It was the same day that Aberdeen had the 9 inches of rain and flooded about half the city. And I had been going for 36 hours straight, no, about 24 hours straight. And I was with none other than the legendary Keith Sharisky on an ambulance. And we were called to deliver about 30 miles outside of Aberdeen to the east and to the north. And we got on scene. We had a brand new paramedic with us that day. And he showed up the next day after all of this. We had a flood in Aberdeen and he delivered a baby on his first day. So if I was him, I probably would have ran for the hills, but he showed up again. And yeah, we delivered. It went good. If you ever talk to Keith about it, Keith will get a big old grin on his face and say that he held that baby the entire way to the hospital. That was number 6 for mom. And our guys had delivered with her on her 5th one as well in about the same place. So she was totally fine. She was a trooper. She knew what was happening. The crazy thing is that the rescue squad who we were intercepting with, they had gotten her loaded into their ambulance. They drove about a half a mile and realized that their alternator was going out. So I was in our ambulance. I pulled up behind them. We got mom out, put her on our cot because the cots weren't interchangeable at that time. Put her on our cot. I jumped in the back of the ambulance, and it wasn't 5 minutes and we had an infant. So that's my story. Still a pretty cool one to this day. Does anybody else have any stories on that they want to kind of talk about? No, yes. Anybody else on the call? Has anybody delivered one in the field? You can put it in the chat. It's okay. Nope. All right. I hope you guys can still hear me. All right. Anybody else? Questions, comments, concerns, anything? All right. Well, Michaela, anything?
Nope, I think we are good.
All right. Well, got you guys out a little bit early. Hope you guys got something out of it. And I hope you all have a happy and safe holiday season. And we'll see you guys all again in 2023. If there's anything you need before that, let one of us know and we can help you out. So have a good night and we'll see you guys all again.